Good morning. Our names are Dr. Maria Benedetto, Dr. Vittorio Ferrari. We both work as consultant anesthetist and intensivist in the cardiothoracic and vascular department in Sant'Orsola Malpighi University Hospital, Bologna, Italy. We thank EACTA committee for the invitation. We are going to talk about a very hot topic in COVID-19, the hemostatic disorder. So the question is, may COVID-19 be classified as hemostatic disorder? Before starting, we declare no conflicts of interest. And this webcast has been reviewed by Professor Serfrex. The scientific community has wondered if COVID-19 may be classified and defined as a state of hypercoagulability, and the early epidemiological studies on Chinese patients affected by SARS-CoV-2 virus had already shown possible hemostatic disorders. So let's start from the most frequent laboratory findings in an ICU COVID-19 patient. Lymphopenia at the blood count test, generally a low prothrombin time and high D-dimer levels at coagulation tests, and high levels of interleukin-2, interleukin-6 in particular, and tumor necrosis factor alpha. This is one of the first reports published on Lancet where it was demonstrated a relationship between clotting system and the virus. 16% of COVID patients had a decreased APTT, 30% of them had a decreased PT, and 36% of them had increased D-dimer levels. But to understand how a pathogen like SARS-CoV-2 virus may affect the coagulation, we need to highlight the concept of immunothrombosis. Immunothrombosis represents the relationship between pathogens and coagulation. In response to the pathogen, associated molecular patterns, PAMPs, or damage-associated molecular patterns, DAMPs, monocytes and their microvesicles express and deliver activated intravascular tissue factor to the sites of pathogen exposure. This triggers the extrinsic pathway of coagulation. Neutrophil extracellular traps, which are called NETs, are lattices consisting of DNA and histons, and they support immunothrombosis through several pathways. 4 mechanisms are mainly involved. First of all, NETs can directly activate factor 12, the contact pathway of coagulation, probably through the negative charge surface. NETs bind von Willebrand factor and support the recruitment of platelets. The histone H3 and H4 present in NET's surface can trigger the activation of platelets. And NETs locally concentrate enzymes such as neutrophil and elastase, which respectively cleave and oxidize anticoagulants, including tissue factor, pathway inhibition, and thrombobotulinum. Immunothrombosis and its central components provide all of the crucial defense strategies, including pathogen recognition, pathogen compartmentalization and trapping, prevention of pathogen spreading and invasion, and pathogen killing, as well as allowing for the establishment of an adaptive immune response and immune memory. During immunothrombosis, the contact against the pathogen is restricted to the intravascular compartment and thus triggers minimal host parenchymal damage. A deadly complication in sepsis is represented by disseminated intravascular coagulation, DIC. Instead, systemic bleeding is a more common feature in non-septic fibrinolytic phenotype of DIC. Sepsis induces cellular damage and cell death, releasing various cellular components that further propagate inflammation. As we mentioned in the previous slide, host-released pro-inflammatory substances are known as damage-associated molecular patterns, DAMPs, and they play key roles in the innate immune system and tissue repair. DAMPs also contribute to the pathogenesis of inflammation and thrombogenesis. NETs can also trigger DIC. The sepsis-associated DIC has been called SIC, and the International Society of Thrombosis and Haemostasis recently proposed a simpler version for the diagnosis of SIC, which is composed of only 3 items: infection with organ dysfunction, mainly due to reduced tissue perfusion, platelet count, and prothrombin time. Sepsis-associated DIC criteria were developed by members of the International Society of Thrombosis and Haemostasis in 2017 in order to categorize patients with sepsis and coagulation disorders. The SOFA score was included to confer the presence of sepsis, but does not reflect the sepsis severity itself. This is another Chinese study on 41 COVID-19 patients. In this study, published on Lancet, prothrombin time and dimer levels were higher in ICU than non-ICU patients. Levels of D-dimer, high-sensitivity cardiac troponin I, serum ferritin, lactate dehydrogenase, and interleukin-6 were clearly elevated in non-survivors compared with survivors throughout the clinical course. Older age, higher SOFA score, and dimer greater than 1 microgram per milliliter at admission were associated with increased odds of death. In a more recent study, still in press, the non-survivor revealed significantly higher D-dimer and fibrin degradation product levels when compared to survivor at ICU admission, and antithrombin levels were significantly lower in non-survivors. This suggested that conventional coagulation parameters during the course of COVID-19 pneumonia were associated with prognosis, and 71.4% of non-survivors met the criteria of severe DIC, at least 4 points. This is another recent still in press article on COVID-19 patients from Panigale et al. That clearly shows a state of hypercoagulability, as you can see from this viscoelastic test. Furthermore, 93% of COVID patients showed an R interval under the mean value, 90% of them had a K interval under the mean value, and MA was under the mean value in 13% of cases. But now the question is COVID-19 a true DIC? The answer is no. Only part of results shown so far are confirmed in this report by Panigale, that is to say, an increased D-dimer level. However, other signs of DIC, such as prolonged PTA-PTT, are not always confirmed. Other signs of DIC, such as reduced platelet count and low fibrinoid activity, are normal or even increased and do not support the consumption coagulopathy concept. The reason for this discrepancy is still unclear. Probably the virus prolongs coagulation time, but when the coagulation starts, then becomes grossly hypercoagulable. And what about our ICU COVID-19 patients? We had similar findings. The mean D-dimer level was 4 mg per liter, and 34% of patients had a D-dimer over the upper limit of reference range. The mean INR we found was 1.17, with 73% of patients having INR under the upper limit. The mean APTT ratio was 1.3, the mean fibrinogen level was over the reference range, 443 mg per deciliter. And what about interleukin-6? The mean interleukin-6 levels were pretty high, 384 picogram per milliliters, with 97% of patients with interleukin-6 over the upper limit, and they correlate with severity of clinical and chest CT scan findings. Lymphopenia was a common feature, and sometimes alteration of eosinophils have been found. Half of patients analyzed showed a low anti-factor A levels. We started testing anti-factor A in patients with poor renal function and a glomerular filtration rate under 20 milliliters per minute, receiving prophylactic dose of low molecular weight heparin. Once having understood that patient probably needed a therapeutic dose of enoxaparin, we started testing anti-factor A in all patients, basically by the end of March. Mean platelet count was in range, with only 25% of patients having platelet count under the lower limit. We did